All right, everybody, can you guys hear me? Welcome to this is actually the second live review we're doing. We did one last month on some neuroanatomy concepts. We checked out strokes and visual field defects and some neurotrauma and hydrocephalus in that session. And if you missed that one, I'd make sure we have it in our YouTube channel. You can check it out at your convenience. It's about, I think, 50 minutes long, so it's not too bad. So this one today, we just got, we're going to go through some cranial nerves. Just going to give you a background on us real quick as we're waiting for some other people to join in. So this is put together by Da Vinci Academy, which some of you may follow us on Instagram or subscribe to our YouTube channel or Twitter. We appreciate you guys following us, supporting us. Really appreciate it. This is our website if you want to check out more content that we have. So really, what kind of content do we have? We have outline format textbooks with corresponding online video courses. We have that for anatomy and biochemistry. Anatomy is a 310-page book with over 200 diagrams and radiology images. Biochem is a little shorter. It's about 139 pages. And then many of you may be familiar with Da Vinci Cases, which is our free weekly clinical case video series on YouTube and Instagram. We put out some nice previews from those. We've got links to all this stuff in the description, along with some other information you guys may find useful. These are just our packages. You can find us on our website. The link's in the video description. Again, you can do a 7-day free trial, see if you like it. You can cancel at any time. Otherwise, this is just our month-to-month prices. So if you want to check us out, that'd be great. All right, thanks. So the session plan today is really we're just going to go through 3 clinical cases covering cranial nerves. I think the best way to learn cranial nerves, obviously you got to have like the basic fundamentals down, but I think learning them in a clinically relevant context is what's most useful and helps you make them most memorable. And this is usually how you're going to see this on exams, both your school exams, whether you're in medical school or dental school or graduate school or maybe even some residency training exams as well, and then obviously the board exams as well. Feel free to ask questions as we go along. You can put them in the comments and they'll pop up, and I'll try and answer them as quick as I can. All right, so we've got the first case here. Again, I try to have a little picture because in a lot of these exams, you got to be able to identify certain things. So we'll go through those. So the first case, we've got a 42-year-old woman. Presents with complaints of hoarseness, so a hoarse voice, swallowing difficulties, abnormal taste sensation, and then a drooping right shoulder. So some interesting presentation. On oral exam, she's got an absent gag reflex. We'll get into why that's significant in a second. And then if you look into her exam, obviously this would be the right, this would be the left. And so you can see that she has a deviated uvula to the left. Physical exams notable for scapular winging and then weakness of rotating the head to the left. So what are the key clinical findings here? So we want to think about this. Take a second. So the list here, we'll want to explain kind of the causes behind each of these. So we've got a 42-year-old woman. The big thing there is that she's healthy. She's got no chronic conditions that the stem really warns us about. So that's really what you can take away from that. Hoarseness or hoarse voice. So this is the laryngeal muscles, which are innervated by the recurrent laryngeal nerve, which is a branch of cranial nerve 10, the vagus nerve. So whenever you see a hoarse voice, you want to be thinking about recurrent laryngeal nerve. Some examples of also where you can see a hoarse voice is, after surgery, after specifically neck surgery, like thyroid surgery, sometimes cervical spine surgery, you can see that can be a complication. So you want to be thinking about recurrent laryngeal with hoarse voice. So swallowing difficulties. So we want to think about that. So again, that's going to be mainly your palatal-glossal and levator velar palatine muscles. And again, these are innervated by your cranial nerve 10, your vagus nerve. I see you guys commenting in. Thanks for putting your input in. Appreciate it. So abnormal taste sensation. So taste is actually due to some of the embryological development of the tongue. The tongue, in a sense, has its own dermatomes when it comes to taste. So we want to think about that. It could be cranial nerve 7, 9, or 10. So let's think about the tongue here. If we break it down, so the anterior 2/3 is cranial nerve 7, which is the facial nerve. So we have a branch of the facial nerve doing that. And then the posterior 1/3 is glossopharyngeal nerve. So it could be, and then cranial nerve 10 does do some taste, but it's not mainly the tongue. It's usually like the epiglottis and some of the posterior aspect of the oropharynx. So we'll keep these guys in mind. So drooping shoulder, this is going to be your right trapezius muscle, and that's going to be innervated by your accessory nerve. And so definitely want to be, we definitely, given that she's got this severely drooping right shoulder, we definitely want to be suspicious of cranial nerve 11. So absent gag reflex. So with these reflexes, guys, there's a sensory limb and then a motor limb. Anybody want to take a guess at what the sensory and the motor limbs are? Either one? So the sensory limb is the glossopharyngeal nerve, and then which makes sense because it does a lot of the not just taste but general sensation of the posterior tongue and of the oropharynx as well. And then the motor is going to be cranial nerve 10 because it innervates a lot of those oropharyngeal muscles. So that's going to be your gag reflex. Scapular winging. So we want to think about that. So that's going to be your trapezius in this case. So that's, again, going to be your spinal accessory, cranial nerve 11. Another thing that can cause scapular winging, as you guys may be aware of, is the long thoracic nerve. That's a branch off the brachial plexus. Now, that's not likely in this case because that's, that's usually you see that. A common question that we'll ask that is if a woman had a breast cancer surgery where they remove some of the axillary nodes. Again, they don't describe that in the immediate history here, so we're not as suspicious. So I just wanted to make you guys just make a point of that because you can see that on exams a lot. So cranial nerve 11. No, you're good. You're good. I'm glad you guys are throwing in some guesses here. That's what it's all about. So lastly here, weakness, rotating to the left. So that's going to be your right sternocleidomastoid muscle, which is cranial nerve 11 again. So rotating to the left. So remember, the sternocleidomastoid muscle, it rotates the head to the contralateral side. So the right sternocleidomastoid is going to rotate the head to the left, and then the left is going to rotate to the right, if that makes sense. So vice versa. So you want to keep that straight. Test writers like to trip you up on that. And so you definitely want to be aware of that. So we're seeing some common themes here. Cranial nerve 10, potentially 7. Obviously, spinal accessory is making an appearance here in a lot of these. Cranial nerve 9. So definitely kind of starting to get a picture here of what's going on with this patient. So how about the oral exam? We take a look. We kind of pointed this out already. If you look at this, the uvula is deviated away from the side of the lesion. So if we do the right, do the left, obviously it's deviated this side. You also see failure to rise. That's because these muscles are very weak. So why is that? Weakness of the soft palate muscles, and so we want to pay attention to that as well. And again, what about abnormal taste sensation? So we talked about this already. Could be cranial nerve 7, 9, or 10. Now let's think about this here for a second. Cranial nerve 7. We don't talk about any other facial nerve deficits because, for example, you would ask someone to raise their eyebrows or to close their eyes or to smile, show you their teeth. Not seeing any of that on the presentation, so it's not as likely. Cranial nerve 10, like I said, it contributes much more to taste than cranial nerve 9, contributes glossopharyngeal, contributes much more to taste than cranial nerve 10. So I think it's going to be, as far as her taste abnormalities, it's going to be most likely this cranial nerve 9. So we want to think about where's the lesion. So we've got these 3 nerves impacted here. We've got the vagus, the glossopharyngeal, spinal accessory. So anyone want to take a guess where the lesion is? I'll give you a hint. It's in the skull base. No takers? All right. So let's pull up an MRI. Maybe this will help you. So we've got a mass here, a tumor, as you can see here. And then if we bring it in, it's a meningioma at the jugular foramen. And so you're going to have compression of cranial nerve 9, 10, and 11. And you can see that here. Here's the jugular foramen. Here's the internal jugular vein exiting out. And you see these cranial nerve 9, 10, and then here's cranial nerve 11 here. So definitely something to pay attention. You want to know these foramens very well because obviously if a tumor compresses them, it's going to cause some crazy symptoms, compressing a lot of different cranial nerves. So definitely want to pay attention to that. So that's our first case. Next case here, we've got a 50-year-old man presents with a chief complaint of vague headaches. Also, if you guys had any questions on the last one, just let me know and we can go back to any part of it. But just want to keep this moving. I know I don't want to take up too much of your time today. So anyways, we've got a 50-year-old man with chief complaint of vague headaches. Patient also relates that he's gained significant weight over the past few months, particularly in the abdominal and the upper back regions and in his face. So the exam findings, we see the diagram here. So let's see here. So this is without holding the left eyelid. And so you can see he's got kind of significant drooping of his eyelid here. And then if you hold his left eyelid open, if we look at his eye here, it's kind of pointing down and out. And then if you look at his pupil, his left pupil is much more dilated than his right. And this is when looking straight ahead. So he's got absent pupillary light reflex in the left eye. That's not surprising. He's essentially got a blown pupil here, but intact corneal reflex. So we want to think about what are the key clinical findings here. So I'll list them out here for you guys. So chief complaint of vague headaches, left eye is down and out. We've got mydriasis, dilated pupil, also known as a blown pupil. We got ptosis, and then we got this significant weight gain that's going on. So we want to think about what this left eye is down and out. So we want to explain this. So we want to think about what this means. So if we look here at the left eye, so these are the muscles. So this would be superior rectus, lateral rectus, inferior rectus, medial rectus, inferior oblique, and superior oblique. Now these arrows correspond to the movements of these muscles. Here they are again. Here's superior oblique here, superior rectus here, lateral rectus here, and then you've got actually inferior rectus here, and then inferior oblique here. So if we think about the movements here of the eye, so superior rectus is pretty easy. It goes up. Inferior rectus, it goes down. Medial rectus, it goes medially or inward, and then lateral rectus goes out laterally. Now the obliques are a little bit more tricky. So inferior oblique, if you think about, or let's start with superior oblique because you can see it really nicely here. So if you look at this, it's almost like a pulley system. And so it wraps around this pulley and then it turns, and then it's actually going to turn the eye upwards and laterally. So superior laterally. And then that's going to be inferior oblique. And then superior oblique, or excuse me, I misspoke there. So superior oblique is going to turn it downwards and outwards like this. So that's what it's going to do for that. And then inferior oblique will do the opposite. We'll turn it upward and laterally as well. So the problem here, the problem here is that the eye is deviated out this way. So what we've had here is you want to think about the muscles acting in equilibrium. So if all muscles are intact, the eye obviously will be looking straight ahead. However, if you lose medial rectus, that's going to cause it to go outward like this. And then if you lose superior rectus and inferior rectus, again, it's going to lose that opposing force. And so with cranial nerve 3 does medial rectus, superior rectus, inferior rectus, and then inferior oblique, versus superior oblique has its own nerve, cranial nerve 6, and then, cranial nerve 4. Cranial nerve 4, and then lateral rectus is cranial nerve 6, the abducens nerve, and then the trochlear nerve. So what appears to be happening here is that the trochlear nerve and the abducens nerve are acting completely unopposed, because superior oblique can act completely unopposed and push the eye down and out, and then lateral rectus helps contribute to that. And so that makes sense here. If you look at this diagram here of superior rectus. Okay, so you got a question about Horner syndrome. So Horner syndrome, we'll talk about Horner syndrome here for a second. So Horner syndrome, it's a good question because you can present with similar. So Horner syndrome you can remember with PAM. So you have ptosis. The problem is this is partial ptosis. I'll explain the difference here in a few slides. So our patient has full ptosis, and I'll explain why you can tell. And then A stands for anhidrosis, which means deinnervation of the sweat glands in the head and neck region. So you're gonna have like dry skin is really how they'll describe that. And the M stands for meiosis, which is actually pupillary constriction versus dilation. So based on that, I would not say our patient has Horner syndrome, because they have the opposite of meiosis. They have mydriasis. There's not really any mention of dry skin or lack of sweating going on in the head and neck. And then they have full ptosis versus partial ptosis. But good question, good point there, good comment. Thanks for that. So if we look at the ocular motor nerve here, so the ocular motor nerve has a superior division, and then they have an inferior division, as we see here. So the superior division goes up here and innervates superior rectus muscle, levator palpebrae superioris. That's the muscle that raises the eyelid. We'll talk about that in a second. And then it comes down here and has an inferior division that does inferior rectus muscle and then inferior oblique muscle. And then if you look here, let's look at the cranial nerves here. Cranial nerve 6 innervates lateral rectus, and then cranial nerve 4 innervates superior oblique. And so again, superior oblique and lateral rectus, since they each have their own nerves, they're not innervated by cranial nerve 3. It's able to go down and out. So lastly here, the left pupil is dilated. So let's look at the autonomic innervation of the pupil here. So if we look at the cranial nerve 3 here in this diagram, so we've got cranial nerve 3 here, provides some sympathetic efferent output here, and then you have, which goes to the sphincter pupillae, which is the muscle that will constrict. So again, the eyelid, or the muscles of the eye here, it's the same kind of thing as being in equilibrium. So if both are acting, the eye is going to be about the pupil will be a neutral size, versus if, in this case, if you've lost this because you've lost cranial nerve 3, you're going to have the sphincter, the dilator pupillae muscle, which is innervated here by the cervical sympathetic nerves here, is going to go completely unopposed, and so it's going to fully dilate because you've lost this parasympathetic input from the cranial nerve 3 here to cause constriction of the pupil. So that explains why you have left pupil is dilated. So again, that points to a cranial nerve 3 lesion. So again, here, just to sum this up, the eye is down. In a cranial nerve palsy, you're going to look for the eye is down and out when looking straight ahead. You can see that here. Again, that's because superior oblique and lateral rectus are acting completely unopposed. And so this is exactly the motion in superior oblique, because again, you don't have any opposing force from medial rectus, inferior rectus, superior rectus, or inferior oblique. You're going to have mydriasis because, again, like I said, you've lost this input to the sphincter pupillae, which would have constricted the pupil. So these cervical sympathetic inputs going to the dilator pupillae muscle are going to act completely unopposed and then give you this, this dilated pupil here. And then complete ptosis of the eye, and we'll talk about that in a second. So here we go. Explain this fine. So we've got this loss of superior rectus, inferior rectus, medial rectus, inferior oblique, cranial nerve 3. Again, loss of sphincter pupillae, parasympathetic fibers in cranial nerve 3. So I want to explain the ptosis here. So let's talk about complete ptosis versus partial ptosis. And this is where your comment about Horner syndrome will come in again. So complete ptosis is what our patient has. It's drooping of the eyelid that covers the entire eye. So you can see that like this. versus partial ptosis, the eyelid droops, but it only droops a partial amount. Hence, that's why it's called that. So complete ptosis is caused by paralysis of the levator palpebrae superioris muscle, which is innervated by somatic fibers coming from cranial nerve 3. So we look here, here's levator palpebrae superioris muscle, and as you can see here, and then you can see where it's really coming in here and attaching to the upper eyelid. You can also see it here. Here's the tendon of the levator palpebrae superioris attaching here. And so, as you can see, that's the major muscle that moves the eyelid up. Versus partial ptosis, this is caused by paralysis of the superior tarsal muscle, which, as you can see here in this figure here, superior tarsal muscle, it's sort of an extension of the levator palpebrae superioris muscle. So it's like a helper in a sense. It helps the levator palpebrae superioris raise the muscle. So in partial ptosis, you've only lost the superior tarsal muscle, which is innervated, has different innervation, and it's innervated by the cervical sympathetic efferent fibers. So this is what you'll get with Horner syndrome, because Horner syndrome is due to damage to the cervical sympathetic efferent fibers. And then again, here's just a diagram showing that again. So here's the ocular motor nerve, here's the superior division, and then here it is innervating to the levator palpebrae superioris. Awesome. Sure, no problem. Glad this is that cleared some things up for you. So now we've kind of got to, it's looking like cranial nerve 3 is the main culprit here. So the last thing we want to think about here in the case is what hormone do you think is elevated here, or what do you think what do you think explains this significant weight gain over the last few months, particularly in the abdominal and the upper back regions and in the face? So that's the last thing we want to think about here, because that's going to tell us about what is caused. That will give us some insight into what's causing this cranial nerve 3 palsy. So it's actually not the thyroid hormone. It's actually increased ACTH, adrenal corticotropin hormone, and ACTH, if you recall here from this axis, so you have CRH, which gets released from the hypothalamus. It comes down and it stimulates ACTH release from the anterior pituitary gland. ACTH goes to the adrenal gland and stimulates production of cortisol. So this patient has significantly elevated levels of ACTH and cortisol. And so cortisol is going to go and cause metabolic effects. And then the thing here is that high cortisol levels, cortisol causes a number of things, but it causes significant weight gain, particularly in the abdominal and the upper back regions and in the face. And this is a hallmark presentation of Cushing's disease or Cushing's syndrome. Now, high cortisol can cause a number of other problems, but this is the most classic clinical presentation. So you want to think about why is ACTH increased here? Because if you look at this, cortisol comes back and it provides negative feedback to the pituitary gland, so that it should be decreasing ACTH if you have high levels of cortisol. Should also be negative feedback on the hypothalamus and causing decreased levels of CRH release. Well, the reason for that is because this patient would have a tumor of the pituitary gland, a pituitary adenoma, which is continuously secreting ACTH. So you're continuously secreting ACTH, and so it's not affected by, well, I suppose this feedback would still occur, but the problem is it doesn't matter because this negative feedback doesn't occur, and then the problem is that you still have this pituitary adenoma acting completely on its own, autonomously secreting ACTH. You can see there's some other tumors that'll secrete ACTH. There's some lung tumors as well, so it's definitely, you want to pay attention to that tumors can do that on their own. So we want to kind of summarize what's going on in this patient. So we've got a cranial nerve 3 palsy, as you can see here. We've got Cushing's disease. So if we look at the summary here, this is a cross section. This is a cross section of the cavernous sinus, and so here's our guy right here, the ocular motor nerve. And so what must be happening in this patient is if you have a pituitary tumor, here I'll draw it in a different color because that do it in black here. If you've got a tumor here of the pituitary, it can come out here and potentially compress on cranial nerve 3. Now, look, there's a lot of nerves that are coming through here. This is one case example I use. There's obviously other cranial nerves here that can be impacted. So sometimes a pituitary tumor, it just depends where it is, the nature of the tumor. Sometimes tumors can go out more this way and affect maybe the trochlear nerve instead. It just depends on, every patient's going to be different. So this is why you got to go off the whole picture, the presentation, and then also the fact that they have this history of Cushing's disease that they've been developing. So again, here's just a coronal MRI of the tumor here. And so you can see where it's gotten pretty large and out of control here. And so a tumor like this has got to be removed. Question here, kind of follow-up, is which bone will the surgeon go through to remove this tumor? This is kind of more of a surgical anatomy question, but it gives you an idea of what it makes you think about where the pituitary is in the skull base. If there's any thoughts on that. So it actually goes through the sphenoid bone. So this is a pretty cool surgery. Yeah, exactly. You got the question right. It's sphenoid. So it's a transsphenoidal approach. You can see here, the surgeon will use his instruments and go through the sphenoid bone, which is right here, and debulk the tumor and remove the tumor like that. So that's just kind of an interesting follow-up question there. All right, so this is our last case. This is the third case. If anyone has any questions on those first two cases, just let me know. We can go back at any point. Appreciate you guys making comments and participating as well. So a third case here. So there's going to be, I'm just going to forewarn you here, there's a lot going on in this case. So we'll try to go step by step, walk you through all the different presentations and put it all together at the end. So here we've got a 45-year-old patient that fell down several stairs and hit his head hard on the concrete wall on a concrete wall in the right orbital frontal region. Patient presents with left periorbital edema and bruising. That's not surprising. He just got smacked in the face, basically. And then numbness of the left frontal region. Patient's conscious, aware, and responsive, so it didn't knock him out. He's able to answer questions. He's able to be responsive. He knows where he is. So that's always important when you're dealing with patients with neurotrauma like this. So the head and neck exam, so he's got left eyelid ptosis. And so I'm sorry, I forgot to mark it here in the diagram. So this is when holding the eyelid open. Should say that here. So this is for all, as for all of these. So he has left eyelid ptosis. I'll tell you he has full ptosis. Should have made note of that. So he's got full ptosis, no acute deficit in visual acuity, so his vision's intact. He's got minimally elevated left intraocular pressure. Again, it's not too surprising. He got pretty banged up in that region there. Left pupil is dilated compared to the right. You can see that here. Here's the pupil dilated like this. He has an absent pupillary reflex, and then he has full restriction of motion of the left eye in all fields of gaze. So this is what this diagram is showing you. So you look, you'll ask the patient to look right, to the right here. As you can see, his eye stays still. Then you ask them to look this way, his eye still stays still. You ask them to look down, his eye stays still. And then you ask him to look up, and his left eye stays still. So you can definitely see these on board exams, on the USMLE exam that likes to do stuff like this, where they'll have you have these different scenarios of where they're looking. And so you definitely want to be aware of that. So all this is basically telling you is that his eye, the ocular motor, or the extraocular muscles are in complete paralysis because he can't move this eye anywhere. He's also got limited range of motion in his jaw. And then lastly here, there's no evidence of optic nerve edema, neuropathy, or retinal detachment. So if we look at the key findings in the history here, he fell down some stairs. Again, he hit the right. He had a severe blunt trauma to the right orbital frontal region. He's got left periorbital edema and bruising, numbness on the left region. So he's got left periorbital edema and bruising, numbness on the left frontal region, left eyelid ptosis, no acute deficit in visual acuity, and then the left pupil is dilated compared to the right, absent pupillary reflex, and then full restriction of motion in the left eye in all fields of gaze, and then limited range of motion. So we kind of want to go through all of these here and think about what's responsible for these. So if we look at the left periorbital edema and bruising, that's, again, we said that already, that's just inflammation from the trauma. That's just from getting hit in the face. Numbness of the left frontal region, so that's the ophthalmic division of the trigeminal nerve. If we draw a face here, so if we have the nose like this, we have a mouth like this, and the eyes like this. So the ophthalmic nerve is going to, so if you have V1, is going to do sort of this region around the eyes down into the nose like this. And then you have the sort of middle of the face is the maxillary nerve, and then the jaw, or the lower portion of the face, is going to be the mandibular nerve. So that's going to correspond to the ophthalmic division, where he's having this numbness in the left frontal region. The left eyelid ptosis, we talked about this with the previous case, is levator palpebrae superioris, which is the ocular motor nerve, cranial nerve 3. So now we're starting to put together the picture where we're thinking about cranial nerve V1, cranial nerve 3. He's got no acute deficit in visual acuity. So I mentioned this already. That means his optic nerve is most likely intact because he can see. Left pupil is dilated compared to the right. So we've talked about this a little bit as well. So he's lost those parasympathetics to the pupillary sphincter in cranial nerve 3. Absent pupillary reflex. So that's going to be the afferent, which would be cranial nerve 2, is the afferent because you're shining light in that has to get received by the optic nerve, and then what will allow you to blink your your pupil to constrict in response to that is the cranial nerve 3. Now, full restriction of motion of the left eye in all fields of gaze. So this isn't just cranial nerve 3 because he can't move his eye anywhere. He tries to move it to the left, he can't move it. He tries to move it in this direction, he can't move it. Down, up, he's not able to do it at all. So that's going to be all of these nerves are going to be affected. Cranial nerve 3, 4, and 6 are all affected here. And then limited range of the motion, limited range jaw motion. So we want to think about what this is all about. It's not cranial nerve V3 because he has intact sensation in cranial nerve, the V3 dermatome. They only mentioned that he's got the numbness in this left frontal region here. So lastly here, we want to think about the normal findings. So kind of summarize, this table just kind of summarizes everything. There's no acute deficit in visual acuity. So he's got a normal optic nerve, normal skin sensation in this dermatome here. However, he's got numbness in the left frontal region. So that's the ophthalmic nerve, left eyelid ptosis, levator palpebrae superioris, which is cranial nerve 3. His left pupil is dilated compared to the right. So he's got loss of the parasympathetics to the pupillary sphincter. And then likely here, this absent pupillary reflex is due to cranial nerve 3, not cranial nerve 2, because his vision is intact. So again, we're seeing a recurrent theme here. And then lastly here, he's got full restriction of cranial nerve 3, 4, and 6 here. And so here's his imaging, just to give you a look. If we zoom in here, let's do it on. If we look at this portion here, this is where you want to pay attention to. Think about this is where he's got a significant fracture, as you can see here. And so again, he's got superior orbital fissure is constricted due to this zygomatical maxillary complex fracture, as you can see here. And so that's leading to his superior orbital being constricted. And if you remember, cranial nerve 3, 4, and ophthalmic nerve all travel through the superior orbital fissure. So as a result of that, those nerves are getting severely constricted. And so that's what explains his total paralysis of his extraocular eye movements, that numbness in the orbital region, frontal orbital region there. And again, due to also the cranial nerve 3 palsy, that explains his blown pupil and as well. So that summarizes our case right there. So that's it. That's all I've got for you today. Sort of a shorter session than the last one. Again, just a reminder, check out Da Vinci Cases. We put this out every Wednesday on YouTube. If you haven't subscribed to us yet, make sure you subscribe. Appreciate all you guys that have subscribed. Make sure you check out our anatomy and biochemistry books if you're looking for some good resources for that, and our video courses on our website at dviacademy.com. We have some individual tutoring available as well if you email this email address. And then if you haven't already, follow us on social media. Here's our website, and then our Instagram, Twitter, and Facebook. I know a lot of you guys already do. Again, really, really appreciate you guys, following us, commenting on our posts, liking our posts, and viewing our content. I hope it's helpful to you guys. Hope you liked this session. Please give me some feedback on it. Either put it in, comment on the video below, or send us a direct message on Facebook or Instagram or Twitter, whichever one you follow us on. Definitely want to hear that this was helpful. We like doing these live reviews. I think it's a great way to interact with people who are following us, and we're happy to do it. And we're trying to do it about once a month here, trying to do just a free live review on a topic. And so if you want some more practice cranial nerves, we've got 2 videos, some 2 Da Vinci Cases cranial nerve videos I put the links in the description of the video, the YouTube video there. So you can definitely check those out. It's also, if you just click our channel, you can find them on there as well. And then a number of other neuroanatomy videos as well. So, in our playlist there. So, all right, guys, thanks again. Really appreciate it. Again, give me your feedback. Love to hear from you. All right, thanks. Of course, happy to provide it, guys. Glad you got something out of it. All right, guys, I'm gonna end the stream now. Take care. Again, feel free to message us. Keep an eye out for our content.